of the PVC. It was only with a bipolar application that we rendered that we were able to stop the PVC here. This is the important patient. Patient was having tachycardiomyopathy with 30% PVCs there. This is just another example that we are going to the RVOT and the cusp. And by delivering, putting applications on the right side and the left side, since we are not able to completely eliminate the PVC, sometimes they decrease in number, but they're always back. One of the options that we have is just to go for a bipolar ablation. Again, and I agree with Pasquale, but sometimes what you want is to have your 35 watts application delivered in a smarter way. It's not simply going up to 50 watts inside the aortic cusp. I don't have that, I don't feel safe delivering 50 watts there. It seems that if I have to deliver my 30 watts in a bipolar mode, this can be better in terms of eliminating that outflow tract PVC. This is the data that we published some years ago, so it seems to be an option if you are not able, if you have good electrograms, but you are not able to stop the PVC. Another application is to use epi and endo, and also for deep septal VTs. Epi and endo, as you can see here, as I told you, there is always a high initial impedance with a significant drop there, and that drop is not going to increase the risk of pop, because again, it's just a result of increasing tissue temperature in both sides of the wall. It's also interesting to note that termination is always long. It takes more than 10-15 seconds for VT to stop, and that makes sense. Because if we're dealing with an intramural circuit, and you put a bipolar setup, and it stops in 2 seconds, it's because your map, your previous ablation wasn't done properly. So if it's a truly deep septal, truly intramural VT, it will take longer, but it will succeed. That makes sense. This is just another example when we have two catheters in both sides of the wall, RV and LV, and as we map the situation, as we map these two conditions here, trying to deal with deep septal VTs, in some of the patients we can actually render these VTs non-inducible. This was the data that I had, and as you can see here, we were able to treat some patients. As I told you, time for termination, it was always long, which makes sense in this kind of setup. So just to have an opportunity to discuss, I think bipolar ablation, it's a safe option for deep intramural AT, PVC, and VT. It seems to be more effective than sequential unipolar despite later termination, which I just told you. It's safer than simultaneous unipolar ablation despite massive impedance drop. Because if I'm doing simultaneous unipolar, I'm injecting 50 watts in both sides of the wall. So it's basically delivering 100 watts application. If I'm using bipolar, because it's alternating current, I'm actually dealing with 50 watts in a smarter way to deliver that amount of power. There is always a higher probability of achieving transmurality with this kind of application, especially if the catheters are less than 15 millimeters apart. And we have experience with AT and VTs, and of course, it's more experience is needed for us to apply this kind of modality to more patients. There was a trial that was being conducted in Europe, in the US. I don't know what happened, if the trial had to be interrupted, and I was trying to find some results, but I could not. But I'm happy to answer any questions. Thank you for your attention.
Andre, very nice presentation. So we heard, different talks and different approaches to try and maximize the efficacy of ablation using radiofrequency energy. But I get more and more the sense that we are sort of reaching a ceiling effect on the amount of energy that we can deliver with the current technology that we have. To what extent do you feel like we need to keep working on modifying the biophysical parameters as opposed to just switching to another source of energy?
I think when you look at the history of EP, the only thing that remains the same over the last 15 years, it's the use of unipolar RF. and RF by itself. So I agree with you. Working with constant power RF generators and being able to deliver just a low voltage, I don't see a future there. For some specific problems, yes, but if you're dealing with massive substrates like AFib, like VT, we got to change the way we deliver RF or simply switch completely to a new way of new energies, such as electroporation or things like that. We just have to be careful that I'm not sure if we can already add 2 patches, bipolar, and half saline. Patients will pop, and that's what we don't want to go.
Andrew, I have a question. In our bipolar experience, we found some patients with endocardial thrombosis post-bipolar, and I personally had 2 cases of late embolic MI 2 weeks later after I did bipolar ablation. They were in the study, actually. So the question is, do you have a sense why that happens? And because after that, we changed the practice in a way that every single bipolar case, we do oral anticoagulation for at least a month afterwards.
I had a similar case like that. Just a question for you. This was with the new software, or this is when we did not know what kind of impedance we were dealing with in the new software? Yeah, because we had a case, the only case we had an important clot in the RV was a patient with vasculitis, and he had an embolic event too. So I think it has to be related to the damage that we're causing to the endothelium and some cratering, some cavitation in one of the sides of the wall. And I agree with you. If you're to go for bipolar, we should, and we do the same thing. We keep the patient anticoagulated for a much longer period of time, sometimes 3 months.
Any other question from the audience? Andre, bipolar ablation is quite an old technique. John Kahn used it in post-receptor accessory pathways a long time ago. But now, in this meeting, particularly in this session, we have seen several other options to increase lesion depth. What's your vision concerning the most effective technique to increase the lesion size? Do you still pick bipolar ablation, or you rather go for half normal saline or other technique?
Well, it's different, right? So when we want to increase, I'm not sure if I'm increasing the size of the lesion, because with the bipolar setup, my impedance is higher, my current density will be lower. So I like bipolar because it's a safer way to deliver the same amount of current or even less current. So if you change the impedance manipulating the patches, or if you use half a normal saline, you can increase the current too much. So I think if I was able to switch from one to different strategies, I would like to start with bipolar first and then manipulate the impedance and go back to my regular unipolar. So I think we have to balance between being able to increase the current density and then have a complication.
My concern is what Pasquale was just saying, that we were not expecting this embolic complications because of all this theoretical advantage of delivering less current density with bipolar. But I think it's still valid, and especially for those structures like the RVOT, that you don't want to deliver 50 watts there. So it makes more sense for me to deliver current in a smart direction and try to get rid of the substrate instead of simply increasing the amount of current by increasing the power there.
Thank you very much, Andrea, for this terrific talk. And we're going to the very last presentation of this meeting, which will be given by Dr. Miguel Valderrábano from Houston, United States, which is entitled Alcohol Ablation for Inaccessible Sites, Anatomy, Technique, and Cumulated Experience. Miguel, please.